Well, good evening, everyone. It's so great to see each of you. My name is Erin, and I'm a palliative care nurse originally from Canada, but I've been living in Kenya for the last several years, and I'm really excited to be leading the call today. I'm representing PallCHASE, which is an organization that, or a network that works to promote palliative care in humanitarian settings. And we're really excited to be able to connect with Starlight Oasis of Hope Hospice that has been running this session in collaboration with Africa Palliative Care Association too. We are really delighted tonight to be focusing on a very clinical topic. We are on our 4th week, so you may have been joining this session. Some of you are going to be listening to this recording afterwards, but we're really glad that you're here. We have 8 sessions in total in this introduction to palliative care and limited resource settings. And we're really excited to be led tonight by Dr. Dalene. She is a physician from South Africa and is currently based in Bloemfontein and focuses on adult palliative care. Tonight, we're going to be talking about symptom management in palliative care through individuals' journey with serious illness and into end-of-life care. We are going to be covering a lot of material, so we do understand if some of it you may want to review afterwards. I'll try my best to get our slides up in our PDF form so you can review them this week. But I will encourage each of you to do old school paper and pen. If there is a topic that you would like to review, and you don't want to forget it, please do write it down. I always have a paper and pen, and I was talking to DeBello earlier today how she keeps organized with all of her to-do lists, but go back to the original paper and pen. If you have a note or a topic that you'd like to review, please do write it down for yourself. If you would like to get in touch with any of our faculty members, you can see that they have a hashtag in front of them, and several of them have introduced themselves in the chat. It's really great to see each of you. So if you're just joining us, I would love to do a really fun activity just before I hand it over to you, Dr. Dalene. Can you guys describe for us your day in one word? So we just did a little bit of a self-care activity to kind of recenter us. Now we're going to do a funny game. So you have only one word. You could be very positive, you could be very negative, you can be very funny. I'm interested to hear what Joan, our senior palliative care nurse, has. I'm just joking, Joan, there's no pressure. But write in the chat one word on how your day was and then push enter so we'll all see how everyone is doing. Very good. Loaded, unpredictable, busy. My day was overwhelmed, stressful, tiring. Oh, energetic. Good. We've got some people sharing. Good. Joan had a fulfilling day. Perfect. Nice. You had a funny day. Great. Good, stressful, positive. See, this is the thing. We all come into these kind of calls coming from a different perspective. And I think continuing medical education is never easy. There's never the right time to sign into a call or to learn something new. But I do hope that we can just take the next hour or so, hour and 15 minutes, and just focus. Again, thanks for being with us today. Oh, I see someone is freezing. I hope you have access to some sort of heat. In Kenya, we call them a jiko. I don't know what it's called in Lesotho, but I hope you have a warm blanket if you don't have anything else. So, Dr. Dalene, I hand it over to you, and let me get the presentation going, and you're welcome to introduce yourself.
All right, thanks. Thank you again for the privilege to be part of this group. You know, the training in this specific training program in Lesotho is very near to my heart. I'm working in Universitas Hospital and also obviously the oncology department. And if I look at our statistics, you know, Lesotho would be, we've got 5 provinces, and if we put Lesotho there as the 6th province, then we get the 3rd most referrals or back referrals from the patients that we see in palliative care is actually patients that we need to down refer back to Lesotho. So that's really, really, that's actually quite a lot of patients, and it's so important that we that we work together. I will provide my email address. My Dr. Hassan actually has got that, and my cell number. You are anytime really more than welcome to make connections with us in Bloemfontein, so that we are really sure that we are working together and that we are doing the best we can for our patients. You can go on to the learning the objectives slide. I'm just talking. There's quite a lot of information, so I'm going to go quickly through it and really try to focus on the things which I think is really important. It's important to understand the basics of the important things of symptom control, and that's what I'm going to focus on. So we are, if a patient, okay, if we just think about the definition again, then we know treating physical symptoms is very important in a patient to be able to improve a patient's quality of life. You cannot even try to improve quality of life if there's pain or a patient is vomiting or any of those symptoms is available. We know the patients that the symptoms that the patients experience is extremely stressful for the families, and particularly if the patient is at home and the family are the primary carers, and it's so important that we discuss the way we manage symptoms with the families as well, so that they are really equipped and they understand the medication and that they know what they can give safely when to the patient if they are alone with the patient. The other thing which is really important is that when you have to manage a symptom, we always try and determine what exactly we think is causing the particular symptom, and then try and reverse the cause, identify the cause and treat the cause. And obviously, you will do this taking in consideration where the patient is in his or her disease trajectory. And that will often determine the type of treatment that we will use for the patient. So and you can go on to the next slide, but we're going to focus mainly today on dyspnea. We're going to look at nausea and vomiting, a little bit, and anxiety and delirium, and a word or two on secretions. All right, next slide. Good. So let me get there. So if it comes to dyspnea, so firstly, what is dyspnea or shortness of breath? So it's that patient's awareness that I am unable to breathe. And obviously it's when the oxygen supply and the oxygen demand have a mismatch. So that feeling of, I cannot breathe. And that is obviously a very, very distressful symptom for the patient. Now, depending on the underlying disease, there could be multiple reasons for dyspnea in a patient. And firstly, because we are usually working quite a lot with patients with cancers, the tumor infiltration, putting pressure on the airway or infiltrating and destroying a lot of lung tissue is a very common reason for a patient to experience dyspnea. And obviously, if it's a relatively new diagnosis in a young patient with a good ECOG, one would try and alleviate symptoms by more active treatment. So that would be the type of patient where you might start the patient on steroids. And I've looked at your standard treatment guidelines. You've got dexamethasone available. So if you have that, then I would start the patient on dexamethasone. But you can also use oral prednisone or whatever you have available. And that would be the type of patient that you would immediately discuss with oncology to see if there's any way that one can actually get that patient in quickly so that you can actually do radiation. Now, we know there's always a problem with radiation. The spaces are really difficult, but because the radiation machines are usually fully booked. But this is really important that one do discuss to see whether there wouldn't be a space, because just a single radiation episode would, can already help to reduce the tumor size and improve the symptoms for the patient. Other important reversible things is look at infection. And if the patient is not an end-of-life patient, if you are certain that treating the infection would improve the quality of life, then definitely one would like to treat the infection. COPD, heart failure, pulmonary emboli, we know these patients are at very high risk of developing a pulmonary embolus, and one will still treat it, particularly if it's earlier on in the disease trajectory. Obviously, if it's a patient that's already nearer to end of life and you are not sure what is causing the sudden onset, you expect it can be a pulmonary emboli, but it's not a patient where you would transfer for further investigations, or or a patient that is already terminally sick, then one might focus more on the symptom management. COPD, heart failure, that is often a comorbidity in patients with cancers, and it is important to examine the patient carefully, listen for wheezes, etc., because you can always alleviate the shortness of breath significantly by using, beta agonists like your salbutamol, etc., using corticosteroids. And obviously, if it's heart failure and you suspect that there might be underlying fluid that has built up, pulmonary edema, those patients usually respond quite quickly to a single dose of 40 milligrams of furosemide. So again, you have to look at the patient, examine the patient thoroughly, and these are the things that one can try. Your patient with a respiratory muscle weakness, most of our neurological diseases will lead to respiratory muscle weakness, and in some patients, if there's certain funds available, one would be able to use a non-invasive ventilation like your CPAP or your BiPAP, but often, we have patients that doesn't have that means, and you don't have that available. And then again, you will completely focus on alleviating the perception of being short of breath, and we will talk about that. Make sure that there's not a pleural effusion or massive ascites, because both of those could influence or could cause shortness of breath. And in some instances, it's actually not that difficult to do a pleural tap or to tap the ascites. Anemia, severe anemia could lead to shortness of breath, and depending again on where your patient is in the disease trajectory, one might find it, important that you actually transfuse the patient. It's really important because, as with pain, we talk about total pain, and that the similar principles will also be applicable to shortness of breath. So one has to evaluate your patient very carefully in all the different domains. This emotional impact, and the social impact, and the spiritual impact, the cultural impact, because all of these things will have a direct effect on the symptoms that the patient experiences. And we all know fear, how many patients are full of fear of what is going on with them. The financial distress, the fact that they're experiencing their body as deteriorating, and they know that they're not able to do whatever they normally do. And these things cause a tremendous amount of anxiety. And also remember the vicious circle of, feeling short of breath, that making you anxious, and your anxiety then just increasing the shortness of breath. And these are things that is really, easily treated, with using your benzos. Next slide. So in the management, so you start with doing a complete evaluation of the patient, examining the patient. If you are able to do special investigations in a hospital, one will do that. But we know often we cannot do that because you are at home, go to the patient's home, and you just cannot do special investigations. So what is really important is to talk to the patient and the family about what is going on. We often in hospitals, which rely quite a lot on, things like a saturation meter, you would look, and the way the patient is breathing. It's important to realize that we have to stand at our patients, the end of the bed, and you look at your patient, even if your saturation meter is low, because we know those things are not always that reliable. So you look at the patient and see if you see the patient being uncomfortable. And if the patient is uncomfortable, then you have to treat the patient. And as we said, apart from addressing a specific cause of the disease, which you can actually reverse and therefore improving quality of life, often, if you cannot reverse something, then we need to use therapeutic agents. And the aim of the therapeutic agents is mostly to alter the patient's perception of the dyspnea. There's quite a lot of non-pharmacological things which you always need to do. So the movement of air in front of the patient is very important. And cold facial stimulation. So putting a, cold, something on the patient's face, and positioning the patient in an upright position, making sure that the environment is quiet and calm. The place of oxygen. We often struggle to get oxygen for palliative care patients because the procedure in South Africa to get oxygen is usually such a prolonged procedure that we often really struggle to get it. And I think it is important that one really needs to evaluate whether the patient really needs oxygen. If there's a clear improvement in the symptoms when the patient is on oxygen and you are able to get it, then obviously that is what you would do. But often you find that the oxygen is mostly causing movement of air, which you can actually do in other ways. And sometimes the oxygen is more there for us or for the families than really causing improvement in the patient. So, often patients wouldn't need oxygen. I think one just needs to evaluate it really well. Then in terms of the treatment, the pharmacological treatment. So as we said, identify the cause and treat the cause as far as possible. And then the agents that we basically have is our opiates. And our opiates plays quite an important role in alleviate the perception of the patient that I cannot breathe. The mechanism by which the opiates it usually just works in the baroreceptor area in the midbrain, where it decreases sensitivity to the CO2 level, and the patient feels as if they can breathe easier. And similarly, there's also some cognitive changes, and that also can cause the patient to feel slightly better. Literature usually talks about 20 milligrams in a patient that's not on morphine for anything else. About 20 milligrams of morphine is usually the dose that would alleviate anxiety. Obviously, I know you guys struggle to get oral morphine. So if you only have the long-acting agent, then 10 milligrams BD should usually be okay. I don't think you have a lower dose than that. But I would usually prefer, if you have the setup available, to start at a lower dose, particularly in your elderly patients, and your very, very frail patients, they would be more sensitive to the morphine. And I always try to start with a lower regular dose and then rather add extra dosages for breakthrough, times of severe dyspnea. So that would be your morphine. And then we already discussed the others. If there's infection, antibiotics, treat the cough, use steroids, use your furosemide, use your inhalations, your beta-2 agonists, as well as your steroid inhalations. If there's any indication that the patient is struggling, there's wheezes and that there's bronchoconstriction. And then make sure that your patient is not anxious. I've seen that you, on your essential drug list, that you do have oral diazepam available. I also saw the lorazepam, I think, and that it was both available as as a vial, as well as oral tablets. But you can actually use any of the available benzodiazepines. The lowest possible dose. Usually start very low, and you can go up on your dose slowly, and you monitor your patient frequently to make sure that you do not cause sedation, because that's not what you want to do. You want to keep your patient, or the ability of the patient to have contact with the family is really important. So don't over-sedate the patient, but make sure that you are alleviating the anxiety. The next slide. In children, as I said, I'm not an expert in children, but from what I've read, again, remember, you're sitting with the child, but you're also sitting with the parents and their anxiety, and having to see a child that is struggling to breathe. And often, when you see somebody else suffering, even if that person is actually not suffering from the symptom, but you can have the perception that the patient is suffering, and that increases everything really. So make sure that you go through carefully with the parents, explaining to them everything that is happening, making sure that the resuscitation status is in place, that we know that we are all in the same page in terms of goals of care, reversing whatever you can reverse, and your treatment in children. The next slide, you will see there's just different dosages for kids. Erin, you can move. Thank you. So your position of the patient is important. Again, as we said with children, oxygen if it's appropriate. If you have to use a suction, very carefully, and we try and do suction only in the mouth. Again, reversing reversible causes, and then of course, the dosages of your opiates and your anxiolyticums, as we will use it in children. So just make sure. I've been aware that you do not have midazolam available, but I saw clonazepam as well on your EDL, and even diazepam. If you use that in extremely low dosages, then that would be great. In terms of nausea, so similarly to what we said with all the other symptoms, you have to understand the symptom and what is the different things that can cause the symptom, because nausea is not just nausea. Similarly to what we've just discussed with dyspnea, shortness of breath. One, try and identify the cause of that, and then you treat it specifically according to the cause. So there's different areas in the brain that plays an important role in nausea, the perception of nausea, and the process of vomiting. And the first area obviously would be the cortex, and in the cortex is where fear is, pain is, anticipation of chemo, or anticipation of something bad happens. That's where the sight of certain things and smells of certain things are, and the cortex, most of the role that the cortex would play in causing nausea and vomiting would definitely be by using, again, our benzodiazepine. So your fear, treat your pain effectively, address smells and sights of wounds, etc. And the anticipation fear, as well as with normal fear, the use of our benzos usually plays a very important role. And again, as we said previously, lowest possible dose that can actually cause or help the patient to feel better. Then we have in blue the vestibulary area and the cerebellum, so that's usually related to your balance. And in that area of the brain, so your balance and the inner ear plays a part there. So obviously any disturbance in that area will lead to nausea and vomiting. That area is rich of mainly your muscarinic receptors and your histaminic receptors. So that's why we want to use something with anticholinergic effects that blocks the muscarinic receptors. And most of your old generation antihistamines are very effective in treating nausea and vomiting that comes from that area. And I've seen on your list you've got phenergan, promethazine, 25 milligrams of promethazine. You've got it in a tablet form. You've got it in a vial. You cannot give it subcutaneously, so you can only give it intramuscular, deep intramuscular, or you can use it intravenously. But you have it available. You also have cyclizine on your EDL. So, as an oral tablet, so cyclizine also would be a good agent to use in a patient that has nausea and vomiting due to motion disturbances or due to any problem in the cerebellum, and balance abnormalities. Then your chemoreceptor trigger zone area, which is in the fourth ventricle. So that area is just outside of your blood-brain barrier. And that area is sensitive to electrolyte abnormalities. So your patients that present with high calcium levels, hormonal abnormalities, opiates, and many other drugs can trigger this area, chemotherapy, anesthetics, etc. So quite a toxins, a lot of things can trigger this area directly and leads to nausea and vomiting. There's multiple receptors in that area, but we know that our old metoclopramide, which is available in the Sutu, both as a tablet and as a vial, 10 milligram vial, is available, and it's very effective to treat any symptoms that comes from that area, or you suspect that would be the reason for the patient's nausea and vomiting. And then lastly, you've got your intestine, where we have our vagus nerve, and we also have certain, so again, your muscarinic receptors, but also some of your serotonin receptors. And anything that affects the stomach or the small bowel can often, in patients with advanced cancer, you often get stomach outflow, gastric outflow obstruction, and that can then again leads to patients being very nauseous. And particularly, it's important also to listen at bowel sounds. So if your bowel sounds is decreased, that's usually an indication that you can actually help the patient with something that would stimulate bowel movement. And we know, or a prokinetic agent, and we know our metoclopramide is a prokinetic agent. Remember, the mechanism by which it's a prokinetic agent, although metoclopramide blocks dopamine receptors, but it also has an effect on your vagus nerve and the muscarinic receptors in the vagus nerve, and it's via that mechanism that it acts as a prokinetic. Now, I'm sure most of you will know, we always say, do not use something like bethylbromide or buscopan or any other anticholinergic agent together with metoclopramide. And the main reason we say that is if you want the vagus effect of metoclopramide, you're going to cancel that effect if you use an anticholinergic agent. So that's why we say please do not combine the two unless it's a patient where you do not need a prokinetic agent. Then you can actually combine the two quite safely. The only one that's not in this graph would be a patient where you think there's definite signs of increased intracranial pressure due to a lesion, in the brain. And obviously we use, again, dexamethasone for that. That would work the best for that type of nausea and vomiting. But you can also use together with that something like cyclizine, because there's often effect the blue area as well when there's increased intracranial pressure. So something that blocks muscarinic receptors as well as histamine receptors helps for that. So I think we've already said most of these things. So when a patient is nauseous, you try and identify the cause, and if you can correct the cause, then absolutely that is what one should try and do. Always make sure that it's not medication that caused the nausea and vomiting. And I'm pretty sure you spoke last week about the fact that if you start the patient on an opiate, you must always also then start the patient on an anti-nausea agent. And I will usually, when I start the patient on opiates, I will prescribe, continuous dose of something like metoclopramide for the first few days, just to prevent them from getting nauseous. It's important that you cannot use your oral route in a patient that's vomiting extensively, and you can use metoclopramide. You can use it subcutaneously, so that usually helps, to use another route. And always look at constipation again, because constipation and nausea and vomiting goes absolutely hand in hand. Control whatever you can control in your environment. There's next slide. There's quite a lot of non-pharmacological agents that one can use, and I'm thinking about ginger and other things like this. Avoiding strong smells, providing smaller, often cold dishes to a patient that doesn't have a strong smell. Don't give the patient, one plate that's filled with food. Really small portions sometimes helps. And make sure you treat constipation, and just also make sure that, these patients with advanced cancer are all at a very high risk of a gastric ulcer or gastritis. So make sure that you are covering the stomach, by avoiding drugs that can make it worse, or by giving them something like, like a PPI or cimetidine or ranitidine or whatever you have available, to make sure that we are protecting the patient's stomachs. So now the next slide, I've already said everything on that slide. You can carry on. We've covered that. Next slide, covered that. So this is just to explain to you the receptors, as I've already said, so we can carry on. So just then quickly a word or two on the individual drugs. Metoclopramide, it's available in your country both as an oral drug and as a vial, and you can use it per os, you can use it subcutaneously, you can use it intravenously, and we also said as a prokinetic agent. Now, the problem with using a prokinetic agent in a patient that has bowel obstruction is it's obviously one of the contraindications. So it's important that you listen to the bowel sounds. And if there's increased bowel sounds, or the patient is complaining of cramps, then you should not use, and you suspect that the reason for the vomiting is in fact that there might be some signs of bowel obstruction, then you should rather stay away from metoclopramide. In those patients, we usually use a combination of your steroids. If you have access to dexamethasone, you would use that in combination with cyclizine. Remember, cyclizine works on histamine receptors and cholinergic receptors, so you can use cyclizine, or you can use promethazine, which you also have available, and you have it available as a vial, so you can use it intravenously, or you can haloperidol. Haloperidol is also a second line, but haloperidol is also one that you can use in patients where your metoclopramide is actually contraindicated. All right, next slide. Domperidone, you don't have, it causes EPS and QT prolongation. So I don't know what we don't use domperidone at all. And we've spoken about haloperidol. Haloperidol in patients specifically with bowel obstruction, and in general, there's very good data for the anti-nausea effect of haloperidol in patients with cancers. And then regarding the other antipsychotics, you also have on your EDL, you've got olanzapine. And in South Africa currently, we do not have haloperidol available in a vial. So a patient that cannot take something orally, we are struggling. So we are now going to try to move over to olanzapine, because there's good data for the use of olanzapine in patients that present with different types of nausea and vomiting. And olanzapine, similarly to haloperidol, has quite a wide range of activity. So it mainly blocks dopamine, but it also blocks quite a lot of other receptors, so you can actually use it. The one thing remember about olanzapine is that it's much more sedative than haloperidol. So if you do not want that in a patient, then that would be troublesome. But often if you give it, it's a long acting, the drug acts quite long, so you can give it at night and then it can actually help for sleep. It's got less a risk of causing EPS compared to haloperidol. The medication in children is it's more or less similar to what we've discussed now. Just please look at the dosages. And obviously your kids are more sensitive for EPS. So your dystonic reaction, so be careful there. But again, we use the lowest possible dose that will alleviate the symptom. You reassess your patient continuously so that you can pick up any of these side effects of the drugs that you're going to use, and then one can actually change the drug as change to something else as needed. Next slide, constipation. All right, so we know constipation together with urinary retention is two of the symptoms that you need to develop immediately. See a patient that develops sudden delirium. And we know constipation is so common in our patients because we use all the medication that we use, every drug that has an anticholinergic effect. So block muscarinic receptors will cause constipation. Any drug that stimulates opiate receptors will increase the risk of constipation. Your patient is not moving, your patient is not eating, your patient is not drinking enough water. So all of these things really contribute to constipation. So we must be very, very attentive towards it. And if we diagnose it in a patient, it's important to treat it immediately. And remember, the main thing about constipation is not about how many stools and how often the patient passes stools. It's about the type of stools. If it's hard stools, then that is that would be the diagnosis of constipation. The other thing which is important is also to do a rectal examination in a patient that is struggling, because if you find that the rectum is full of soft feces, that there's a bulk, one can actually try to remove some of it manually, but you can also give an enema to help to get it out. If it's hard stools, that's few hard stools that's in the that fills the rectum, then you need something that can actually hydrate the stools, increase the mass so that you can stimulate bowel movement and get it out. And often you can then also get higher in the bowel areas where there's stool causing a bit of impaction, and it's often needed that we use enema, giving it orally and giving it rectally to get it out and try and push everything out. I can't remember that I saw Senna on your list. I know you've got lactulose there, but Senna obviously is a stimulating agent, and whereas your lactulose is more of a osmotic agent, so it will draw water molecules into the stools, increasing the size of the stools, and that stimulates the movement so that you can actually get the stools out of, rid of the stools. Similarly in children, one needs to be attentive to identify it, and the agents that you use is it's more or less similar. A stool softener or a lubricant if you find these hard stools, a stimulant, your osmotic agent that will get water into the stools, and then you've got your suppositories and your enemas. And again, it's important that one try and alleviate the reason for the constipation as much as possible. Okay, then we move on to anxiety. I hope I'm not going too quickly here. I think we've gone that. We can go on to next one is anxiety. Oh, sorry, you've already moved on. I'm slow. That's good. No, so in terms of anxiety, there's multiple reasons. As we said, remember so many things has changed for your patient once they got their diagnosis, and you need a holistic team approach to address symptoms in your patient. And specifically in terms of anxiety, it's important to include your social worker, if you've got a psychologist, you know, and we usually use a combination of medication to alleviate anxiety in a patient. Complementary treatment on the next slide is important. There's multiple relaxation exercises, you know, imaginary exercises. There's multiple other things that we can try and help our patients, you know, to cope, non-pharmacological ways to cope with their anxiety. And avoid anything that could worsen in terms of caffeine as well as alcohol. Then in terms of the treatment, now again, it will depend on where your patient is in his or her disease trajectory. Most of the patients, when they are terminal ill, suffer with anxiety, and I always make sure that they have some form of a short-acting benzodiazepine available, like diazepam or clonazepam or whichever one you have, so that if the patient experiences anxiety, that they have something that they can take to alleviate the symptoms immediately. If it's early on in a patient's disease and where you still are a bit worried about benzodiazepine dependency, then one can look at your serotonin reuptake inhibitors. I saw on your list that you've got sertraline as well as fluoxetine available. So the problem with fluoxetine, although it's good anxiolytic agent, it initially increases anxiety, decreases appetite, decreases or cause insomnia. So that is usually not the best drug to start the patients on. Sertraline would be better. You also have the good old triptyline available. And you know, triptyline, although it's not necessarily specifically registered for anxiety, we know it helps with insomnia, it increases appetite. So in general, you know, low dose is still a good one to use for patients. Remember, if you want to use it as an only or single agent for anxiety, it takes quite some time to work. So, you know, up to 4 weeks, even longer than that. So if your patient is terminally ill, I would definitely not go this way. You would just contribute to side effects, and I would rather just stick to using a benzo. Next slide. In terms of delirium, so what is a delirium? It's a relatively quick onset of confusion. So and obviously the severity would be vary in a patient. So a patient that and it's a very common problem in patients with advanced illnesses. It is important to remember that a delirium is not a disease. It's not, you know, it's caused by something, and we always need to try and identify what is causing the delirium. The patients are confused. Often, you can go to the next slide. We actually distinguish between a hyperactive delirium and a hypoactive delirium. Your hyperactive delirium is the patient that suddenly becomes restless, irritable, agitated, aggressive. And it is extremely difficult for a family to look after a patient that presents like this. The hypoactive delirium is where your patient completely withdraws and is inactive and not interested in anything around. That, although it's easier to care for a patient like this, it can be very distressful to a family because it's a very sudden onset of a change in the patient's behavior. And sometimes we do find a mixture of the two. The next slide. So it is important to try and identify the cause, and you can go back to your old medical handbooks. I know we always had this abbreviations to look at, you know, we talked about DIMTOP, but that would include things like immediately look at the drugs. What new drugs have I started in the patient? Have I changed the dosages of the drugs? Do I think my patient is suddenly in renal failure, and because my drug like morphine has a metabolite that needs to be excreted via the renal route, and now all of a sudden my patient is toxic of that? You know, have I added any other drug? Your benzos, you know, your anticholinergic agents, all of them can cause a delirium. Is there infection? You know, and sometimes it's a simple infection like a urinary tract infection, which can very easily be treated. And once it's treated, the patient can be, you know, is often easily or much better. Electrolyte disturbances like often calcium, that's extremely high. Multiple other things. And remember, constipation and urinary retention are two of the things that often causes severe delirium. Then it's important to put the patient as far as possible in a quiet and a known space, a reassuring atmosphere, and having family members around the patient that try and makes the patient comfortable. And then in terms of treatment, the most common drug which works so effectively is to use haloperidol. Low dosages of 0.5 milligrams up to a maximum of 5 grams is what we usually try to use over 24 hours, or you can use olanzapine in this patient. And that usually really, together with the non-pharmacological ways and looking at what you think is causing it, that can often alleviate the symptoms. Diazepam, I must just see where are we in terms of time? I think I must just now quickly go through everything because our time is really limited. But you can also use a benzodiazepine. Yeah. So let's quickly carry on. I think in terms of prognosis, I'm not going to talk too much about that. We maybe can just say that how important it is to identify a patient that is actively dying. So those patients where there's a sudden change in their, it sometimes feels to me like you can see them losing weight in those last few days. From day to day, you can actually see them just getting thinner and thinner, and temporal weight loss, places where you would not normally see weight loss. There's a change in the patient's ability to stand up. They become more bedridden, sudden general weakness. Skin colors changing in the breathing pattern, all of those things seen together with the normal disease trajectory is usually an indication that our patient is actively dying. And now one again needs to look very carefully at the different medications that we are using in the patient, and we're only going to give to the patient what is really necessary. The rest we can really stop, and we also need to look carefully at the root and if the patient is still able to swallow. Secretions during the last day or two is caused by weakening of muscles. The patient is not able to cough secretions up, and the secretions cause this often very distressing sound when they are breathing. It's important right through everything to discuss everything with the family, and have the family around, and let them observe whether the patient is uncomfortable. And we only need to treat it if the patient is really uncomfortable. Usually, if you just change the patient's position, you find that sound that you get with the pooling of your secretions, that actually goes away. If it doesn't, and you have suction available, you can do a little bit of suction in the mouth, definitely not deeper than the mouth itself. And if you need to use medication, then you can use atropine eye drops, or you can use your hydroxybutyl, which is available on your EDL. It's available as a tablet, but often patients don't swallow at that stage, so it's you can use it, the vial, and you can use it subcutaneously, 20 milligrams subcutaneously, and that can help to dry up the formation of new secretions. The problem is the secretions that's currently there that you need to get rid of. And they are otherwise, they are there. We not really have time to talk about other things, nutrition, importance of oral care and eye care, and all those type of things. But I'm sure a lot of these things were already addressed as you as you go on through all the different symptoms. And then in terms of pediatrics, in our children, it's so important to make sure that you support the whole family, that you anticipate problems that can occur, anticipate if it's a patient with brain metastasis where convulsion can occur or where bleeding can occur, that is also medication available to address those symptoms, support of the whole family and the parents in a child that is actively dying is really critically important. And I think I'm going to stop there. Yeah, that's a mouthful, I know. Sorry about that.
Thank you, Dr. Dalene. It's been a pleasure to listen to you just speak about all the different things we need to consider while we take care of our patients. And I think I've just been reminded that we probably need to reduce the amount of content that we teach during this session. It is really important. And this is an introduction course to palliative care, but it's actually a really, really important topic. So if there was something that you did as a participant write down during this session that you'd like to spend a little bit more time on, we as a group are available as faculty members or people that have more experience doing palliative care. We definitely want it to be open, and we do have a little bit of time for discussion. We will continue learning through a case presentation. I didn't see if Annalice had joined us. Tabella, did you see if she joined us online?
I think I saw her, unless she dropped off, but I saw her.
Okay. There was a few more.
Erin,
yeah.
I'm there.
Oh, you're here. Oh, great. Oh, nice.
We're rushing from work now, but I'm here.
Thank you, Annalice. Thank you so much. So I'll just invite the faculty to address any questions that people have. Again, we've covered a lot of symptoms tonight. We've covered a lot of medications. Critical things for palliative care are to remember that we want to treat patients' symptoms. We don't want them to suffer with something that is really bothering them. So you may need to reach out to someone who is more specialized in a certain area, depending if you're a nurse or a social worker. This session is very heavy on medications, but it's really important. So again, I will work hard with Tabella this week to make sure that you have access to these slides. You don't need to memorize. I don't think Dr. Dalene would encourage us to memorize all the different medications that are needed, but know where you can go to identify if there is a symptom that's really bothering a patient or a family member addresses a symptom. And do your best to look back to some of these slides, to look back to your drug books that you have in your clinical settings, and find the best thing that you can do to treat these patients.
And I can also just say, particularly, and I don't mean it only for the patients that we are transferring from the palliative care setup in Bloemfontein back to Leostho. Even if you have a patient there that we really need to form after this training, you know, like communication lines, where if you struggle with a particular patient and a particular symptom, that, you know, we can talk to each other and that we can really help, you know, to alleviate the symptoms, because we don't need expensive medication, and most of the medication is either available in your hospital level or, you know, in your primary level.
So I know, again, there was a lot of content we covered. Do please put any questions in the chat. We have many faculty on the call today. So Joan, Christina, Tabello, Jillian, if you see questions kind of come up, please do address them. I am going to hand it over to Annalice because we are now going to shift into our case discussion. The way we've set, we know today is very heavy on content, so we're not going to head into our small groups today. What we're going to do is we're going to ask you to engage with the case on each slide. Annalice is our palliative care nurse that's been working in a refugee camp in Kenya with the International Rescue Committee for the last 10 years. And she is everyone actually needs to applaud her. She just graduated from a diploma in palliative care from Nairobi Hospice and Oxford Brookes University. I'll share a photo with the group. She just graduated on Saturday, which is really exciting. But Annalice is going to walk us through the case. And on each slide, there's going to be a red piece of text of the question that she's going to want you to address in the chat. So if you're on your mobile, find a way to find your chat, or if you're on your computer, just prepare to engage in the case that way. So welcome, Annalice. We're really glad you're with us today. Let me just bring up the presentation. Over to you, Annalice.
Thank you, Erin. Good evening, good morning, good afternoon. I don't need to introduce myself again. I'll go straight to the topic because we are all. Erin. So let us start the study case with our case is, the name is called Temelo. Is a 52-year-old man with the pancreatic cancer, which has metastases to the lung and the liver. Lives in a rural part of Leostho with his wife and 3 sons, aged 1, 3, and 12 years old. Is a former day laborer, has not been able to go to work several months due to worsening symptoms, including shortness of breath and nausea. You visit him at home. The main symptoms. Question to the group. What are some questions you have about his symptoms? What will you ask him, or what will you be thinking in your mind about his symptoms? Let's all share. You can unmute and talk, or you can put in the chat box. Correct? The belly has told us severe pain. Think of somebody with the cancer of the pancreas. Yes, correct. Salone has told us anxiety, shortness of breath due to lungs being involved. What about the liver? The liver is involved. Thank you, itchiness. Marake. Extreme pain and fear. Cecilia, thank you. Yes, vomiting. No, thank you. So as we go through, we all have to think about if the pancreas is involved. We know very well that the insulin is produced in the pancreas. The lungs are used for oxygen exchange. The liver, metabolism takes place in the liver, and so possibility of so many symptoms with our client. Next, Erin. So he reports dyspnea, which we have contributed, anxiety and nausea. Dyspnea rated was at 4/10 and at total rest, and then 8/10 with activity, which means when he's at rest, he feels a bit comfortable, but when he's doing anything, moving or even talking, he feels so dyspneic. Then dyspnea improves with the bronchodilators, airflow, open window, fan, or oxygen. Then his anxiety is a 2/10, except sometimes at night it increases to 6/10. He is nauseated with any smells and with meals. So you can imagine he cannot feed because the smell of food nauseates him. What might be your next steps? Let us contribute. After knowing your patient can only relaxes a bit when he's at total rest, and then he can breathe well when there is airflow, especially when you open windows or you put a fan over him, near him, or you give oxygen. Then he's anxious, and at night it worsens. He's nauseated with any small smell and the meals. So what will you do for the patient to make sure the quality of life? Correct? Thank you. Thank you, health education, minimize any order. Thank you. Educate the patient to avoid hot or spice food, yes. Small doses of morphine and administer antiemetics, yes. Check respiratory level regularly. Thank you. Give oxygen. Supportive counseling. The patient can use peppermint, elevate breathing, positioning. Thank you. As we continue, we continue. Thank you. And then we, after all the contribution, pacing. Thank you. We continue. Timelio has slowly developed ascites in his abdomen, and he has started to have significant nausea and vomiting. There are no clear triggers. He has not had a bowel movement in several days. There is no blood in his vomit. He has no appetite. What are some key questions you need to ask when assessing nausea? When you're assessing nausea and vomiting, what do you ask from the patient or the caretaker? What triggers them? Thank you, Catherine. Characteristic of vomiters, color, consistent, and frequency. Yes. When was the last meal and what was it? When is the onset of vomiting, nausea? What makes it worse? Have they tried anything? Yes. Are they related to meals? Mareke, thank you. When was last bowel movement? Thank you. Tebelio. Onset and frequency, Salone, thank you. Do you feel sick all the time? Do you vomit with little warning? Thank you, Eric. Thank you. Erin, next. Temelio is starting to feel very anxious over his disease progression, especially nighttime. His family, thank you, Mosela. His family is noticing he's becoming more agitated and confused. It is not only distressing to Temelio, but to his family as well. How do you differentiate anxiety versus delirium? How do we differentiate anxiety versus delirium? Dr. Dalene has just told us about delirium, sudden onset. Delirium is of sudden onset. Anxiety is anxiety of slow onset. Thank you, Esther. Anxiety grows gradually, while delirium is of sudden onset. Next, Erin, we shall come back to discuss the difference between anxiety and delirium.
Yeah, for sure. I think we can even bring this back to some of the faculty member. I think we may not have enough information to fully identify. But yes, great. Let's bring it back. Let's continue with the case and then.
Unfortunately, Temelio has continued to decline and he is now minimally alert and not responsive. His breathing has What are some things you can do to treat the symptoms of secretions? What can we do to treat secretions? I think Temelio is reaching his end stage. Yes, sanction secretion and give atropine. Yes. Thank you. Explain to the family. Position changing. Yes. Thank you, Esther. Positioning. Thank you, Salone. We can also give hyacinth, buscopan, to reduce secretions. Dosage is 20 milligram. Next, Erin. Next.
Can you see it now?
Yes. Finally, Temerio died peacefully at home, surrounded by his family. How will you feel about this case? Then what are your fears and worries related to the patient and families as they experience dying and death? Let's go with the first one. How will you feel about this case, Temelio's case? Have we managed him well? Have we given him and the family our best? How will you feel? You can unmute and speak how you will feel about the case. Step.
Bello, you know the group a little bit more. Is there someone that you think on the group would be willing to share? It's not an easy case. So obviously the patient
Not
had
at all.
many symptoms to cover. Annalice, thank you so much for facilitating that. It was great. I think one of the questions maybe to Bello we could address at the end is just how do you feel about this case? How does this make you feel? What are some of your worries as you see patients and families experience death and dying?
I think that is the one that is really speaking to us as individuals, and also speaking to the practice and care that we deliver to our service users and their families. So when we look at how we have managed this case, following Dr. Dalene's perfect presentation, I think we have done well with the management, but is that what is available on the practical level? That is another challenge. I think I would like my colleagues, whoever is happy to share, although we acknowledge it can be a heavy subject, especially because you'll find that it takes us back to our own core and inner cycle, because this is a journey and experience for many of our patients with life-limiting conditions, especially when it comes to cancer. So you'll find that some way or another, it really, really speaks deep to ourselves, and it can be difficult to share when we are still trying to really center our emotions about what we have just realized has been going on with our loved ones, because the trauma has been too much for many of us with regards to people with limiting conditions. So any of our colleagues on the platform, just feel free. If you are happy to share how this case has made you feel, or any reflections of what kind of care we have just learned that will be comprehensive to support the patient and the family, and what is practically a challenge to us, which we can look back and see how we can make changes to wherever we are, or just a thought. Yeah. Dr. Ntuseng, would you like to say something? Dr. Marage.
Hello, Metebello, and hello to all the colleagues on the line. I think this case has been managed quite well, and I feel like the family was made ready because we continuously allayed their fears, let them know what is going on, why the patient is experiencing some of the symptoms. And I think this is the ideal way that we would like all our patients to be managed, especially at the very end of their lives. But I feel like this is where we are lacking as a health system in Lesotho. Perhaps, I don't know whether it's shortage or maybe it's lack of capacity from our healthcare workers. But I feel like we don't really give much attention in terms of preparing the patients as well as the families that indeed this patient is nearing the end of their life. And I remember when I used to work in the surgical ward, we would try and, we had a lot of cancer patients, would try and let the family know what's going on, the condition of the patient, what the prognosis looks like. But we didn't really have a lot of social workers, so we also didn't have a lot of time to spend with the family to prepare them. And you find that sometimes the families didn't take it very well when you tell them the patient's prognosis, as not sharing too much on the prognosis, but at least trying to make them aware that even like referrals to Bloemfontein, because some would say, maybe we can refer to Bloemfontein. Can we discharge the family? I would like to take my mother to Johannesburg for further treatment. So when you try and make them aware that even if you go to Gauteng or wherever, there's not much more that in terms of healthcare that can be provided. There's no cure at this moment. So I think our health system needs capacity. We need the full completion of all the different team members, so that while others are providing nursing care, medicines, but also the social aspect, the emotional aspect is also catered for. So I think that is especially where it's lacking, because in terms of medicines, doing all those clinical things, we do try. Most of the equipment is there, but this social aspect, the emotional aspect, getting the patients ready for this journey of theirs, working through this thing with the patient, with the family especially, I think that is where it's lacking. But in terms of Mr. Tumelo, I think for him, he was managed very well, and I would really love for this to be the kind of care that all our Basotho patients receive. But I do appreciate the gaps that are there in the system. But I think we are well on the way of improving that with this training, and also with the groups that have come before and those that are hopefully will join this training to come. Thank you.
Thank you very much, Dr. Marage. You have said a lot that speaks to an inner core of why this training is going on. Having our colleagues and faculty members from all parts of the world, some of them, it is midnight now. We have got our colleague from India. Only God knows what time it is there now. And we have got all our colleagues that are sacrificing week on week to try and facilitate and really share the knowledge and experience for us in Lesotho to be in a better position in terms of knowledge, so that we can start small, changing and making a difference. But for those of us, which I know they are here, who are in the decision-making capacity, who are in the policy making capacity, it is only my humble plea and prayer that all these kind of cases, they are shared only for one reason, just to see what we might be missing when we are in the offices and dealing with targets and strategic plans and all the deadlines. There are people in their own homes who are suffering, who are seeking medication, who don't get support. We have got social workers that are employed in the communities that should be doing a better job and support our clinical teams in the facilities. We need to create positions for clinical social workers to be back in the health facilities and hospital and be part of multidisciplinary team. Another plea is to acknowledge the need for spiritual and emotional care. We don't need to have chaplains. Only a couple of our child hospitals have got the chaplains within their health facilities. We need them. We need them because we are always rushing around as nurses and doctors. We don't have much time to really allay and reassure them in a deeper and meaningful way. Again, the core of what palliative care is all about is, if you can forget anything, just remember the two things. It's all about total pain, dealing with an individual, not just from physical perspective. They have got emotions, they've got families, they've got social issues, they've got spiritual senses and needs. They also, within African setting, the researchers shows that not only those 4 dimensions of total pain, but there's also an element of finances that is really bolder than we can imagine because of poverty and other challenges within the geopolitical arena. Now, again, multidisciplinary teams, we have been talking about them. The meaningful and impactful need for communication. Gillian and Dr. George, they gave us a session in our second week. It is all about bringing them to the understanding. For as long as they need more information, whatever level of or depth of information they need to be given that information sensitively and compassionately. So Erin, I really felt like this session is a reminder of how immensely the pain is on the ground, because this is the daily suffering of every Mosotho, mostly, not unless you have got something better in your pocket, then you can access better services. You can go to private clinics and take yourself to Bloemfontein without waiting for government a long queue to refer you. And then you can access psychologists and counselors. But for an ordinary person, that is not accessible. Like Dr. Marake says, that is the dream care that we wish to see in Lesotho, and hence why you have all invested as our faculty teams from all over the places to see and support our teams in Lesotho. And I pray that all this investment, we can take them in and appreciate how much preparation that goes behind the scenes, how much sacrifice that at this time of the day, people spare their 1 to 2 hours just to empower people in Lesotho. It's not just to spend time, it is for change, for transformation, for the lasting change, for the benefit of you and I. Who knows who will need this same care that we are envisioning through these sessions. All I can say, thank you, our collaborators, partners, faculty members, our participants, and everyone that is a friend of Starlight. We have got many friends of Starlight on this call, and some of them, they are not necessarily in the social space or even in the clinical health space, but they are so compassionate with the journey that we are trying to unfold and walk in Lesotho. And we thank our colleagues in South Africa. Major, I should tell you and thank you while you are alive, because you have been part of this journey for as long as I can remember. And you never shy back to support what we are trying to establish in Lesotho, not only from your personal connection with Lesotho, but you have been such a dear and compassionate friend of Starlight. And I appreciate that. You have connected us even with all the doctors that look after our cancer patient as they go to Bloemfontein. And that's why we are trying to establish to see how best can we work with them. Because some of them, they try to refer children to Lesotho. There's no service for children. Our Sankatana only takes adults. So we need honestly, my colleagues, as I'm saying this, let us all take the opportunities. I've shared the scholarships and sponsorships with the University of Cape Town. The deadline is on the 30th. If you miss this one, look out for the next one. We just need more people to know more and be able to apply. Starlight is able to do something, but we need more people that will be ambassadors in different areas, different hospitals and different districts. Let's work together for the benefit of our nation. If not us in our generation, who then?
Amen.
Amen.
DeBello, are you sure you're not a preacher? I know, Christina, you had your hand up. Would you like to share a comment?
Pastor Tabella is a very hard act to follow. Tabella, you're such a dear, and you can set it beautifully. I just wrote it in the chat. What I was saying is like, this really calls to mind what Jillian and George were talking about, what Joan always mentions of where are the children in this. And so as we enter the next 2 weeks, we will talk about self-care. We will talk about the social and emotional aspects of total pain. We'll look at a trauma-informed approach and also the spiritual care aspect. So I want to make sure that you know that there are ways to manage symptoms, and that we'll be sharing a lot of those techniques with you, and you have a collective amount of experience here to help support you and walk through this with you. As well as what Tabello has just done, which is that call to action that we need more access to these types of disciplines. So Jillian, I see your hand up.
So no, do finish, Christina.
That was all. I was just getting us to kind of think about that as we head into the next couple of weeks.
Yeah. No, I only wanted to say that when we're thinking about how we think we may have managed the situation, individual members of the family may have quite a different perspective. And often when we talk about the family, it's as if it's one entity. But I guess we all will have worked with families where there are quite deep divisions, misunderstandings, where perhaps the wife wants one thing, a teenager thinks something differently. There's an in-law who's not understanding not wanting to understand what's going on. So it's always, I think, a more complex situation, and we like to think, I think that as somebody is coming close to death, that the family will be concerned and it will draw the family together. But I'm sure we've all had experiences where actually it pushes the family apart. And then it's so important to see how we can support those members after the death, that it doesn't end with the death. That support afterwards is really important, for whatever the age.
Thank you, Jillian. Just as we wrap up, again, tonight was quite focused on symptom management. And I think with access to some basic medication that Dr. Dalene mentioned tonight, really focusing on what is causing the symptoms of your patients. I know identifying a primary diagnosis is not something that is taken for granted. It sometimes is taken for granted, and I know you may not have access to a primary diagnosis always, but we can do symptom management. So to the best of your ability, using your clinical skills, if you're a nurse, if you're a clinician, if you're a social worker, and you can really just sense that a patient is really struggling with a specific symptom, call the nurse, call the physician, the primary healthcare worker that is supporting the patient, and try to really address the symptoms. And yes, again, don't memorize stuff. This might be stuff that you learned several years ago. For some of us, nursing school was 15, 20 years ago, and we may not remember the stuff that we studied. So just know where you can go back to, have your drug books nearby. And again, our team of faculty is always willing to support you. If you have a case where really you feel like you cannot treat symptoms, yeah, please reach out to us. I'm just going to share my screen one more time. This is in celebration with our case presenter tonight, Annalice had a very exciting day on Saturday. She graduated from her diploma in palliative care. Although she's been doing this work and probably could write the textbook for palliative care in refugee camps in Kenya, I think we can all say congratulations to her. Thanks, Annalice.
Congratulations, Annalice.
Yeah.
Thank you all. You supported me.
Congrats. Well done. Wow.
Thank you.
Well done indeed.
And she's
Lovely to
already
see.
back. She's already back in the field. She was in Nairobi for like 48 hours and already back to work.
Wow.
Annalice, you're an
Wonderful.
Thank
inspiration
you.
to many of the people in Lesotho right now that are on the ground. They're not educated. Well, some are educators, but many are frontline workers, Annalice. So you, from this group, can be an inspiration. You worked really hard. You're mid to late career and you've gone back to school. It's really impressive. We're really proud of you.
Yeah, I just want to tell all of us that the journey, palliative journey is not easy, but it calls for determination and that compassion. You just have to create interest and passion for all the people that you look at. And you imagine you are the one on that bed, or you are your sister or your brother, you have to run. When I was here at graduation, I was called, the patient has refused, the patient has done this. But when I came back, I had to rush again to go and visit the very patient. The patient has gangrene of the whole leg and elderly. Was in the hospital. They decided to take home for prayers, which was granted. Fortunately or unfortunately, the patient passed on when I just started morphine for pain. Passed on the very night I arrived back. So yesterday was her burial. You can see that the energy that you put on it is drained, but you have to keep on moving. As a doctor had said that there will be self-care sessions. We should take it seriously that we all need that self-care. Without it, we can also not give our best to our brothers and sisters, our mothers, our daughters and sons. So we just need to have to develop that passion for palliative care. And if we don't make it the way Teberio has said, our generation, who else will? Is us. When you stand, the rest will follow you. But if you sit down, they will also sit down. So we have to stand and take a step. Without, even if there is nothing, you can do something. Just that smile only over the patient is enough to make the relatives see that you really care. The family members will know that there is somebody who cares. That's all I can say. And I encourage that we all go for the training. Palliative care is a good course. It is not easy and cheap the way people say. It is very expensive. But when you put your all in it, you'll acquire skills and knowledge on how to take care of those who do not have anybody to take care of. Thank you. Thank you, Erin.
Thank you, Annalice.
I appreciate you, Erin. You have taken me through. You gave me the strength, the energy. You gave me the motivation to push on. I almost gave up on the way, but you are there for me. Thank you. God bless you abundantly.
Yeah, I think Annalice, Tabella, you have the last word, of course. Annalice does, what is it? You do something from nothing. Really, Annalice does that. So if there are days, and Annalice is very connected on WhatsApp, if there's days where you feel like you are trying to do something for patients and families from nothing, please do reach out to her. She's been there. Okay, Tabella, we should say goodnight.
Oh, I'm sorry. I didn't even notice that the mic is still on. It's just my sound. in the house. Sorry. I just wanted, I think to say, when we talk about cancer challenges like this kind of issues, just to be reminded that we only been blessed with only one oncologist so far in our nation. And it can be an overwhelming task to change around the situation. So as we get knowledge and get empowered with palliative care, let us just be encouraged through the WhatsApp groups to gain confidence, to really sensitize our teams around us, just to drive and move forward, even to suggest whatever the little changes that can be made, just to make the work easier and manageable as we move along for the Lesotho that we envision, which we want. And again, I think, Erin, I just wanted to say, we are coming to a time of Heads-on Day and World Hospice Day. So probably we can think about whether next week or no, not next week, the other week, just maybe the Tuesday before the event, whether we could come along with our beautiful, fancy hats or something, because Starlight, even though it is primarily starting with adults, we acknowledge we are the only hope in the country that has got a dream for the whole nation, not for a district, but for the whole nation to change for better. So we are now really pushing forward that we should remember the children. Major is her slogan now, remember the children. So we have to start wearing our hats as an effort to remember that even little ones have got life-limiting conditions. And then it will also be an indirect way to celebrate the upcoming theme, which says Compassionate Communities Together for Palliative Care, which is our World Hospice Care Day theme. So I think that is all I wanted to share, Erin, just to say thank you to everyone. And I always pray that my heart never takes for granted what the Lord is doing through us, in us, and with us. And I'm just saying, Lesotho is waiting for Dr. Gillian and Dr. George and their team for the physical, practical sessions, so that we can take even rounds to Sankatana, to Queen Mamahado, to see this patient, to see how we can really be in a conversation as a multidisciplinary team. How does it look like? But until such time when the situation allows us, we can't do much, because we have got many stakeholders to allow that to happen. But that was planned for end of October. But whenever the Lord has allowed, we will fly out and be with them. So God bless you all, and thank you.
Thanks, everyone. We'll see you next week, same time, same place.
Thank you.
Bye-bye.
Thank you.
Bye.